I will hand it over to Steph and Rebecca. So once again, thank you.
Thank you. So hopefully you can all see the screen, and hopefully you're the same people who were here last week when we talked, well, 2 weeks ago actually, when we talked about demystifying dementia, the first session. So this is a follow-up session looking at how can we actually implement some of the strategies to supporting people once they receive a diagnosis of dementia, and what can we do in primary care. So let me just get my screens. We also have an acknowledgement of country, and I guess only further to add to what Victoria said is that really we need to understand and remember that the Aboriginal and Torres Strait Islander populations are more heavily affected by dementia and at a younger age, and so we are thinking particularly about our the people who are living with dementia and their carers as well when we're acknowledging, making that acknowledgement of country, and just flagging that there is that very big discrepancy in the presentation of people from those backgrounds.
¿Necesitas que salga?
For
¿Necesitas que
our,
salga? ¿Qué es lo que te puedes explicar mejor?
would you mind, Amelia?
Excuse me,
Everyone
can
just
you make sure your mic is off, please?
Okay, so we do have some learning outcomes, and we're going to talk about the modifiable risk factors that we can actually talk about with patients, you know, from midlife onwards that might slow the onset of dementia. We're going to talk about the goals of care and how we apply goals of care to supporting someone living with dementia. And we're also going to talk about what sort of things can you do when you're implementing a management plan or a care plan for somebody living with dementia. But as it's always a feature of our presentations, we do like to begin with something that you're going to take away at the end. So these are the take-home messages. This is hot off the press. There are now 45% of the dementias that we see are attributable to modifiable risk factors. So actually, that's quite a large proportion. And as you know, in primary care, we really do love to talk about prevention and healthy living. So it really gives us a great deal of things to work with. So that's the first thing to remember. The second thing is that whilst, you know, hopefully you feel a bit more confident about making the diagnosis of dementia, even if you don't, we as the sort of consistent support person in people's lives actually can be very good at also supporting them post-diagnosis. So if you haven't got to the point where you feel comfortable with making the diagnosis, at least hopefully at the end of this you'll be able to take home some real skills in how to best support people living with dementia. And really, whilst there's no current curative treatment available, there are many interventions that we can recommend that actually improve the quality of life for both the person living with dementia and their carer. So those are our 3 take-home messages, and I think we will illustrate those through the next few slides, or the next hour and a half anyway. All right, so just a reminder, Beck, can you remind everyone about making a diagnosis, just in case we've got new people in the audience or in case people want a quick refresher?
Certainly. So to make a diagnosis of dementia, there are 4 inclusion criteria and there are some exclusion criteria. So essentially, we have to see that there's a decline in cognition that is coming on gradually and is progressive. So when we talk about cognition, we're talking not only about short-term memory, but there may be other features like changes to language fluency, changes to executive function, so organisation, judgment, insight, behavioural changes, changes to visuospatial function, changes to attention. So it's a gradual onset, it's progressive in its nature, and to make a dementia diagnosis, there also needs to be significant impact on function from a day-to-day basis. And of course, you need to make sure it's not anything else, which is where the exclusion criteria come in. So firstly, and importantly, I was just talking to Vicky about this earlier, is making sure that somebody doesn't have a delirium. So a delirium is a much more acute in onset, fluctuating level of consciousness, fluctuating level of cognition. Look for any other causes like alcohol or medications. Mental health disorders can also mimic dementia, with the classic being depression. And then checking for other organic conditions, which is where our investigations and our CT scanning come in beneficial. So looking for things like changes to thyroid function, B12, electrolyte imbalances, as well as space-occupying lesions, hydrocephalus, stroke, etc. So once you've ruled these things out, if they fulfill the inclusion criteria, they have a diagnosis of dementia. And it's important also to remember that dementia is not only about cognition. Certainly cognition is a big part, but we need to also note that there are changes in function. So that is the ability to perform instrumental activities of daily living like cooking, cleaning, shopping, driving, banking, etc. We also often see changes in mental health as a part of the dementia. So that can be part of the pathology of the dementia itself. In particular, some people become more anxious, some people will experience depressed mood, and of course we'll also often see things like hallucinations and delusions as well. There are usually some changes to behaviour. These do tend to be more evident in the later stages, but certainly we're looking at things like apathy and withdrawal, which can be fairly early features, but then also expressions of unmet needs, which might be in the way of increase in agitation, for example. And then there are changes in physical health as well. And that is how dementia is a life-limiting condition. Because dementia affects the whole brain, ultimately you will start to see changes in things like gait, continence, and ultimately communication ability and ability to feed oneself. And so dementia is a terminal condition.
Thank you, Beck. So, in order to think about how we're going to support someone with a diagnosis, we also need to think about the different stages of dementia. And that helps us to understand also how we're going to apply goals of care, because the goals of care change as somebody's condition changes. So, just reminding you that stage 1 is really what used to be called mild, but we've taken those kind of descriptors away and just use a number instead. So stage 1, people are still at home, mildly having problems with memory loss, probably having some repetitive questions, loss of interest in their hobbies, but still being able to do, most of their basic activities of daily living and needing perhaps a little bit of support for those instrumental activities of daily living. As that cognition deteriorates and it progresses, then you get escalating care needs, and really that leads to risks in safety, perhaps increase in falls and mobility issues, and that decline in function actually means that people need more and more care within the home, and eventually this is the sort of point when most people are thinking about whether they need to transition to more supported living in perhaps residential aged care facilities. And finally, stage 3 is really what we think of in terms of that palliative phase, where, as Beck said, whole brain is affected, physical immobility is present, and people are having problems with continence and even eating and swallowing. And so, as you can see, we can tailor the support that we give to people based on what stage of their illness they are in. And if you remember from last time, this is that really nice slide that highlights the stages with the domains. And so you can see that cognition and function did decline in parallel to begin with, and then you get this messy area on the right side of the slide where all of the lines are intersecting, which is really that metaphor for what's happening in real life. It's quite a messy time. And the advantage of making a diagnosis when someone has mild cognitive impairment is, firstly, you can institute some risk reduction strategies that might push out the decline. Second of all, you've got time to plan for those more tricky stages later on. So you can have some really good advanced care conversations around what would you do if, what would you do when, so that when you get to those points in time, there's a plan and everyone knows what's happening. And that's, I think, reassuring for people who have a diagnosis of dementia, because most people's ultimate fear is, what am I going to do when I lose my independence? How's that going to affect other people around me? And being able to have those conversations alleviates some of that stress.
Yeah, and we were saying too, weren't we, Steph, that by getting that diagnosis in nice and early, there is good evidence that suggests that if we can provide good education to the carers and to the person living with dementia, it actually enables them to stay living at home for longer, which true. Is really important.
And I think as people don't understand much about dementia, like the general sort of knowledge in the health literacy around this condition is quite low, and so any advice you can give to people about the trajectory and what to do when is really helpful. And you can almost think of those stages as being anticipatory guidance, really, and an explanation. And actually, just recently I've used that picture slide to illustrate to people what's happening as well, and I think that can be really helpful as a tool, just for getting people to understand what's going on when.
Yeah, and often in the hospital system when I was working there, people would be having their diagnosis made at that stage 2, stage 3 sort of point, and it makes it very urgent that suddenly something needs to be done straight away, and it means that people often spend prolonged periods of time in hospital, etc. Sorry, there's somebody here saying, are you showing slides now, as I can't see them?
Oh,
who else can see the slides? I can see them.
Yeah, I can see them. Everyone else, are you able to see them?
Hopefully. I haven't done anything, although I know last time I was doing this, there were some problems with some bits that people couldn't see. But anyway.
There's a lot of thumbs coming up, so that indicates to me that they are. Maybe Karen, we've given you a
Thanks, okay. Cassandra.
Okay,
Thank
good.
you.
All right, so we're going to wind the clock back and talk about actually before diagnosis, so way before diagnosis. So something that we know now is that the pathology that happens for Alzheimer's disease particularly, and certainly some of the other dementias, probably happens in midlife. And so any kind of risk reduction that we can do, really we should be thinking about it from midlife, way before people experience symptoms. And the Lancet Commission and the World Health Organization are, keen on this message of it's never too late and it's never too early to institute some dementia risk reduction. So we talk a lot about this concept of brain health, and I think we've become very familiar with the concept of heart health, and the public are very understanding about what heart health is. And now we need to shift our focus and actually start talking about the brain in the same context. And I think that does two things. One thing it does is, helps people to understand that dementia is not part of normal aging. The second thing it does is it helps bring the conversation into the consulting room. People are very frightened about talking about this sort of conversation. They're fearful about it. And we need, as the health practitioners, to be more proactive in talking about brain health, so that if you talk about it in midlife, when somebody experiences symptoms or they notice symptoms in, perhaps a parent or something, they're able to come and have that conversation with us to talk about what to do next. And it kind of destigmatizes is my sort of belief of how brain health works. So we're going to talk to you about the risk, how do you approach brain health? What is it and what are you going to do in practice? So Beck, talk us through the risk factors for dementia and what's been highlighted recently.
Certainly. So we can see this is a really good graphic representation of the 14 known modifiable risk factors. So you can see there are really two ways to look at this. One is that we do have some protective factors, really, which essentially increase our cognitive reserve. So cognitive reserve is that we have more connections in our brain, so more synapses, neurons talking to neurons. And the way that we develop this is through our education, through learning skills, through languages, music, sport, all those sorts of things to increase the number of synapses. So if you've got a big cognitive reserve, it means that you can suffer more insults before it starts to become evident as a cognitive decline. So we know things like education are really important, and that can start, and that should start in early life. But there is evidence now suggesting that providing education during adulthood and in later life is also helpful at reducing dementia risk. Similarly, things like hearing impairment, that's probably in Australia one of the greatest modifiable risks. We think probably that will also reduce the amount of cognitive stimulation. And so we know that hearing impairment certainly is a risk factor for dementia. And we also know now that the use of hearing aids can somewhat mitigate that risk. And it's also, I think, a really good red flag if you do notice that somebody has hearing impairment to just keep an eye particularly on them in terms of their cognition. So cognitive reserve is one part of it. And then, of course, looking at things like vascular and inflammatory sort of risks is the other. So more common things which we look at in heart health include things like blood pressure, diabetes, smoking, obesity, physical inactivity, excessive alcohol. So they're all very common sense things that we need to modify and manage in terms of vascular risk. The most recent Lancet Commission has just reported that LDLs are also important, and so keeping LDLs below 2 would be the current recommendation. And that's correct, isn't it, Steph? Is it below 2 or below 3?
I think it's below, I think it's below 3. But
it might be below 3. My apologies. I have to reread that. So also the most recent report mentioned visual impairment as well. So ensuring that people have their cataracts fixed and that they've got the most appropriate eyewear is also super important. And as Steph said, this can all happen over the course of the lifespan. There are some risk factors which, if we can address in midlife, are likely to be beneficial sort of later on. And finally, we look at cognitive stimulation through social interaction. So social engagement is really important. I think there's evidence that married couples that married people actually have a slightly reduced risk of developing dementia. We also know that people who have a history of depression have an increased risk for dementia as well. So there's a whole host of things we can do. Whilst there's no direct causal link shown yet between obstructive sleep apnea and dementia, we do know that they're associated. And so certainly trying to regulate sleep apnea should be modified and addressed, and even sort of minimising shift work as well. And then in terms of diet, there's increasing evidence to suggest that a Mediterranean-style diet should be what we're recommending to patients.
Excellent. So, I mean, how I approach this is I use some of the item numbers in the sort of midlife to do some of this. And so you might want to consider that. And in that, or before that appointment, it's also possible to use this resource, which is called the COG-D risk. And it's quite nice to hand out to patients and say, look, you can complete this in your own time. It asks them about all of the risk factors. I think it will probably have to be updated now that there's those new ones. But once you've put them all into the sort of calculator, it does give you this score, and it's looking at what your risk is at the age of 65. So you can do it any time from the age of 18 upwards, but it's actually looking at what your risk would be when you reach the age of 65. And it's a bit of random number, but essentially, although 15 doesn't sound very much, it's still quite high. And it gives you some, things, room for improvement, things that you might focus on. And I think that can be quite motivating for people to actually have a look at those and think, which ones can I target to make a difference?
I think too, Steph, we haven't mentioned it, but, there are some non-modifiable risks, and perhaps they're the people that might come in, or in my experience, that do come in often even more concerned. So we know that age is a non-modifiable risk. As you mentioned at the start, people who are of Aboriginal or Torres Strait Islander descent also have an increased risk. And people who have a family history of Alzheimer's disease do also have an increased risk. And so they are often the ones that come in particularly concerned. And so that might be where the COG-D risk would be a really appropriate thing for them to go home and do themselves.
Yeah, perfect. All right, so we're going to go back to Anna. I'm about to sneeze, and maybe it will go away. It's hay fever season here. Okay, so we're going to go back to Anna. We're going to talk about what actually happens, because I don't think we did the diagnosis. We got up to the point of taking the history and, how we felt about that, but we didn't actually look at what it's like to receive a diagnosis. So we're going to do that now. So if you remember, Anna, she had presented with gradual onset of cognitive impairment. It was progressively getting worse. It had been impacting her function, her ability to do her garden, and she wasn't cooking. She was leaving the stove on. She didn't have any depression. She did have associated objective change, so her mini mental was 22 out of 30. Geriatric depression scale was normal. In terms of functional assessment, we found those things I had already mentioned, and there was none of the exclusion criteria. And Anna was supported by Sophie, and Sophie was quite worried about Anna and how she was going to manage in the future. So I'm going to press the screen in a minute to watch the video, and hopefully you'll be able to hear. If you can't hear anything, let me know. Whilst you're watching the video, I want you to have a think about, firstly, maybe if you've had an experience doing this yourself, how did it go and how did you feel about delivering the diagnosis? Are there things that you think this doctor could do better or might choose to has done well? And perhaps you can pop in the chat any reflections. We're only going to watch a short segment of this video, but I think it is important to just see someone else use the words if you haven't ever used the words yourself.
So Anna, I've had a good look at all of your results, and I'm pleased to say the blood tests are all completely normal and the brain scan showed no sign of a brain tumour.
Okay, good.
But what that means is that the likely diagnosis for the cause of the changes that have occurred for you over the last 6 to 12 months is a form of dementia.
So that's like Alzheimer's.
Like Alzheimer's.
All right, sorry, I've flicked over quickly because I just wanted to move to so the video didn't carry on. Now, does anybody have any comments? That's very short. It's actually only 35 seconds or 37 seconds. Anybody have any comments in the chat? I can't see the chat, Beck, so you'll just have to let me know if there's anyone
I'll keep my eyes out.
There's no comments as yet.
Okay. The things I reflect on when watching that is the importance of being clear about what it is that we're actually diagnosing and being clear about the language that we use. And so the fact that Dr. George uses the language of explaining that this is dementia and isn't using other euphemisms like you have a memory problem or or you just have a bit of confusion, because I think that adds to the lack of health literacy in the community. And so we need to, it's a bit similar to how cancer was, you know, eons ago now probably, but when we used to say a lump or a mass when we didn't want to say cancer. So you do need to use the word dementia. And I do think that actually for many people, they are worried about the possibility that something else is causing the problem. And often I've had people who are concerned about things like brain tumors or other things in their blood. So actually highlighting the normal nature of those tests, I think was a useful thing to do as well. I don't know if you had any reflections, Beck.
Yeah, I mean, I agree with you. I think that using the term dementia is really important. And I've spoken to other colleagues and they sort of use perhaps a slightly more gradated approach, but certainly ultimately ending in making sure that the person is aware that it's a dementia diagnosis. And I like in this instance that Sophie, the daughter, then reflects back and says, like Alzheimer's. So that was a very nice way to confirm what she was saying as well. That was helpful.
And I think this is just like delivering any other sort of serious diagnosis or bad news diagnosis, in that really pretty much after you've said that, you just need to give a bit of time, because and that might be a whole nother appointment another time, because people aren't always ready to hear or take on board much after that initial delivery of the diagnosis. So it might be, it's up to the person, but it might be that at that point, the best thing to do is to schedule several appointments in the future for people to come back. And certainly anecdotally, speaking to lots and lots of people who've been through this, giving people a pile of leaflets and advising them to kind of come back another time isn't best either, because I think they just feel a bit like they didn't get the right measured response. I think it needs to be face-to-face follow-up, and I think it needs to be quite frequent in those first few appointments after the diagnosis to allow people the time to come to terms with and have any questions that they have answered. It's fine to give a couple of resources and a referral to Dementia Australia, but that probably isn't the limit of what we should be offering. So this is our wheel of principles of care of how to look after somebody. And we've put here a person with cognitive impairment. That is because, you know, you might have made a diagnosis of mild cognitive impairment rather than Alzheimer's disease. So this is pretty much what you would do for anybody who has cognitive impairment. So the number one thing is, well, I don't know, these are all number one things. I don't think I could put them in order. But strengths-based approach is really important, and we'll go into a bit more detail about that. But basically, you want to harness the skills that the person still has and maintain them. You really want to keep the person living with dementia central to the process. It should be their goals of care, and your communication should be directed at that person. As I said before, you need time, really a lot of time to talk about this, and having longer appointments for it is really required. You need to be really aware of the language that you use, because I think that can be empowering or disempowering depending on the way that you use it. Recognizing the impact of cognitive impairment on other medical conditions. So that means that other people, people can have problems with their diabetes management or their COPD management because they're not able to manage their medications. You need to involve the people around the person looking after the person living with dementia, because they are integral to that support. And of course, we don't need to do this all on our own. We can use other members of the healthcare team, and that might be the practice nurse, it might be the pharmacist, it could be podiatry, physio. All those people are really important OTs, and we'll talk a bit about what they can do next. All right, so Beck, what about the goals of care? What are our goals of care for people living with dementia?
Yeah, so we have different goals of care depending on the stage. And I think it's really important. You can't stress enough how, as things go, you need to keep reviewing, because as the stages change, our goals of care are going to change. So in mild cognitive impairment, we're really looking at dignity, sort of to try and maintain and limit any impact on function. Stage 1, we're looking at dignity through independence. Stage 2, dignity through safety. And then stage 3, dignity through comfort. And so, continually reassessing things is super important. If we move on, I like this checklist a lot. And actually, we have a snazzy new webpage that's just coming out with Dementia Training Australia, where you can access this checklist. And I do it all the time because I think it gives you visits that you do actually cover all those bits and pieces. And I've even given it to families as well who are super involved, just so that they feel too that they've covered everything that they feel that they need to. But essentially in stage 1, we're looking at education. We talk about those risk factors and ways to modify risk factors again. We arrange medication reviews. We look at some of the legal aspects of things. And we look at safety things, considerations and driving, and then we also sort of address any other sort of comorbidities and changed behaviours. And I would strongly encourage you to do a general practice management plan quite early on and just have that flagged every 3 months for a review.
So what sort of things is it important to educate on? Well, as I've said before, the health literacy is low, so we need to actually be clear about what this diagnosis is. So if it's dementia, what sort of dementia are we thinking? And if we're thinking it's Alzheimer's disease and vascular, a little bit about what that means. It doesn't have to be very scientific, but a little bit about explaining the difference between what is Alzheimer's disease and what is dementia. And so I usually use the language of dementia is describing the symptoms that you're experiencing, and then we look for the causes, and the cause that we think for you is Alzheimer's disease. That causes some proteins or these sticky proteins to form in your brain, which stop the cells in your brain from working properly, and that starts with predominantly the memory center, but then it affects other parts of your brain as well. And as it affects other parts of your brain, so it becomes more difficult for you to carry out your day-to-day activities. So that's sort of plain language how I explain it. Dementia Australia are a really helpful resource, and they will tailor education to the individual. So they offer new post-diagnostic support programs for people with mild cognitive impairment and for people with dementia. And in your local area, that they will have a different setup as to how they do it, but they prefer people to be referred and then for them as the organisation to work out which support service is the best for that individual. And that's because they want it to be motivated by the individual themselves. And if the carer has specific needs, they will divert the carer to a specific carer organised support group. So it's very tailored. And then lots of the PHNs, and I'm sure your PHN has the same, have upgraded their information on the community supports that are available. So that can be a helpful resource as well. And there's another website called Forward with Dementia, which I find really, really neat. It's got just 3 pages on it, so it's easy to navigate. There's one for the person living with dementia, one for the carer or support person, and one for the health practitioner. So for us, it's really useful as well, and all the updates are on there, and you can sign up to their newsletter. But for people to read about some of the education stuff on there, it can be helpful as well.
Yeah, I like Forward with Dementia as well. And I think especially for that, really, those very first few sessions, even just that difficulty in trying to tell your friends and tell your family that news, there's there are pages there on how to approach it. I think it's well worth a look.
There's also a handy little card in there that you can keep in your purse, so that if you're having trouble at the checkout, for example, and you're struggling to remember your PIN, you know, the anxiety of that is quite overwhelming for people. And then you can show this card that just says, I need to have a little bit more time, I've got dementia. And it's not having to verbalize it, it's signposting to someone that you just need a bit more time. And I think that's a really nice thing as well. So yeah, that's on the Forward with Dementia website. You can get access to the dementia guide, which has all sorts of information for you know, if you want to have it in your room. And also Dementia Australia do a prescription pad, which is like a prescription for a referral, so you can fill that in and give it to the patient or send it off for them as well. Another thing I do at the beginning is make sure that people have had a referral to My Aged Care. Again, if your nurse is able to do this for you, then that would be really helpful. And lots of nurses do that. I do it if they're not able to, but I just think helping people navigate these very complex internet-based systems is helpful. So I just try and get them set up on that, and then signpost people to Carer Gateway. And our own organisation has lots of helpful information about dementia as well, which can be for the person living with dementia or the person supporting that person as well. And there's also the Tasmanian University of Tasmania Dementia MOOC as well that is very accessible for people.
I always try and get people to come out. Like, I know it varies from state to state and region to region as to what the wait times are for My Aged Care assessments, but there is a tick box there to make sure that the team actually do come and review the person at home. And, you know, I think if you have any concerns, then it's better if they are seen face to face.
And make sure that there's someone there who can communicate any needs if that's... Yeah.
Yes, because if insight is impaired, then often they will just say that everything's fine. And on the phone, it might be quite convincing. And I think that sometimes it's important that the person actually review what the house is sort of looking like and that sort of thing as well.
And I also think it's important to stress how things can change. So I had a lady today who apparently the daughter's trying to get an ACAT arranged, but there's been a bit of resistance from the ACAT team because they said, you know, she's fine, she's sort of functioning okay, which she is, but the problem is if anything happened to her husband, she would not function at all. So she is functioning because she's part of a unit and her husband is 94, so anything could happen to him at any time, and then she would need respite, and without an ACAT you don't get the respite and residential care codes. So it's really important that you try and advocate for that, otherwise people end up going into hospital and occupying a hospital bed waiting for an aged care assessment. So it's just about being proactive, but I'm not sure that it's always that's always something that people are aware of in the ACAT team, the nature of the relationship between people being very reliant upon each other.
You see it all the time, don't you?
Yeah.
The wheels fall off when somebody has to go into hospital.
Yeah, and I think you just got to be proactive. So another thing that is worth being proactive about is talking about delirium. Now, everybody who has dementia or cognitive impairment is at increased risk of delirium, and I'm sure you've seen many people experience delirium. But what this document is all about is actually a useful education tool to provide families so they can spot delirium as it's, you know, starting off, and use this to engage with health services. So if they notice any of these signs or symptoms, they can alert the general practitioner and get an early review, so that, you know, there's evidence actually that you can minimize the impact of a delirium, and in some cases prevent a delirium by being proactive. So, and many people don't know that delirium can be caused by constipation, medications and dehydration. So I think highlighting that is really important, and yes, that again would potentially reduce the risk for hospital admissions, or at least reduce the length of stay in hospital. Right. So we're back to the risk factors again. I think probably just as a refresher to remind everybody how to think about them. and onto medication. So Beck, what do you advise with medications?
Well, I take medication super seriously. I think I really like it. But I mean, certainly, again, it will change depending on the stage that the person is in. But from the very get-go, I think having a medication review is really important. So I always make a referral for the pharmacist to go and do a home medication review. It's good to talk to the person too about what their desires and wishes are in regards to their medications, because, you know, from a fairly early start, some people, you know, don't like all the medication, don't like the pill burden, etc. And some people are staunchly keen to sort of remain on everything. So having a fairly good understanding fairly early on as to sort of what the person's wishes are can be really useful too. So I think making sure that we've got a medication review. We're looking at streamlining medications. So basically making sure that you've got the dosing in as minimum, so as few doses as possible, the actual administration aids, the easiest that are possible, and ensuring that the person actually knows how to use the administration aids as well. So puffers, as Steph said before, with COPD, and, you know, how to monitor for blood sugars and that sort of thing as well is quite important, just to check that that is something that they can still manage. In terms of remembering to take medications, there are several ways to do it. I'll often organise Webster packing, but also people can have quite elaborate sort of alarm set up. And some families will just, you know, make sure that somebody drops in and visits mum every evening just to check that she's had her tablets for the day. And then there are deprescribing sort of tools that we use. One that I find very useful for people living with dementia is called MatchD. And again, this looks at stage by stage basis, where essentially, you know, in stage 1, you might be starting to consider reducing medications that are trying to prevent things that are going to happen in 20 years. So this is where things like your statins, for example, might no longer be too necessary. Whereas in stage 2, you know, our parameters for what we consider to be okay. So, for example, our blood pressure, blood sugars, HbA1cs, etc., you know, might become a little bit less rigid and strict. And so you might be able to reduce some of those sorts of medications as well. And by stage 3, you're essentially looking at medications that are purely there to sort of maintain comfort. And so minimising pill burden, because we also know at that point things like swallowing becomes much more difficult. And so making sure that the formulations are also set so that they're easy. So, you know, you're looking at drops, at wafers, at crushed medications, and at patches. The other thing that the medication review will do is try and highlight any medications which could actually be impairing cognition. And that's where anticholinergic drug burden is super important. You've all probably heard of it at this point, but we know even that medications that have high anticholinergic load, some of them even in midlife, are now being associated with an increased dementia risk. So definitely looking at medications which are common, things like amitriptyline, oxybutynin, some antihistamines and some antipsychotics are really quite frequently prescribed. And the thing about the anticholinergic drug burden is you can see on this table that different medications carry different point values, but it's a cumulative sort of effect. So it may just be that somebody's on several medications that are sort of 1 and 2 points, but cumulatively they do carry quite an increased anticholinergic drug burden, and we know that that can affect cognition. And to be honest, it's not only cognition, is it, Steph? It's like so many problems that we associate with old age are often due to anticholinergic drug effects. And so, you know, things like dry eyes, dry skin, dry mouth, constipation, urinary retention, they're all potential side effects of these anticholinergic medications. And what you'll often see is that then you start prescribing medication to counteract those side effects. And there's this huge sort of medication cascade that follows. So really important to look at the anticholinergic drug burden. And there are ways in which we can wean and stop. And that's where things like those deprescribing tools can be really helpful to explain, whether you can stop something cold turkey or whether it does need to be weaned, and you watch for certain withdrawal symptoms.
And certainly I've had the case where I've had some people on some really hefty doses of amitriptyline that was used as an antidepressant for the last 30 years. And it's very difficult to make that diagnosis as well in the context of such a high, 200 milligrams of amitriptyline. So sometimes you've got to wean it down to actually see what the underlying cognitive function is as well.
It's so true. And over time, as renal function declines and person's weight changes, they've been on some of these medications for years and years. And you'll also find too, I think, analgesics, which even though they might not have such an anticholinergic effect, often can impair cognition. And, it's very common that people go into hospital, they're put on all this extra medication, and it's very hard to know really what the baseline cognition is until some of it's gone.
That's correct, yeah. All right, so we'll talk a little bit about the medications that we use currently for dementia. So the current, mainstay of medications are the cholinesterase inhibitors. So those are donepezil, rivastigmine, and galantamine. And predominantly, I think donepezil gets prescribed the most. I do use rivastigmine, certainly if that kind of pill burden thing is an issue, or they had side effects from donepezil, then I use one of the other ones as a second line medication. How they're basically working is increasing the I say to people, they're increasing the communication between two cells. So you need the cells to be talking to one another. At the moment, that's being blocked. And so we're putting a chemical back in the brain to allow that communication to happen. There are some PBS criteria. So you do need a mini mental state examination of greater than 10. I kind of just use, if it's a mocha, I just use the same number because it's almost comparable, and I don't want to do a mini mental state as well as a mocha if I've already done a mocha. And it's supposed to be in consultation with a specialist. That doesn't mean the specialist has to have made the diagnosis themselves by seeing the patient themselves. If you work in an area where you've got a good relationship with your geriatrician or neurologist, and you can explain clearly your assessment and why you've reached that diagnosis, then mostly they'll be happy to support you in prescribing that medication. You need to be aware of some of the benefits that people are looking for, and it is quite subtle. It probably works in about 50% of people. About 50% of people don't notice any difference, but in the people who do notice a difference, they will say things are just a little bit clearer, have a little more clarity, sometimes a little less anxious, sometimes a little bit more engaged, sometimes functioning a little bit better, and sometimes it's family members that notice. But it is noticeable in some people, so it is worth trying. There are some side effects, and I always warn people that these are likely to happen in the first 2 weeks, but usually abate after 2 weeks, and they are commonly GI, so often diarrhea, often nausea, sometimes headache. Those are the top 3. There are some contraindications, so severe asthma, severe reflux, or previous ulcer, and you need to really be careful about people who have already got existing cardiac conduction issues. So if they have got an existing issue, you want to do an ECG, make sure they haven't got existing heart block or anything like that. But you don't have to do an ECG before you prescribe. So some people choose to do it routinely, some people just do it if there are known cardiac issues. And these can be prescribed privately as well. So I sometimes prescribe them privately whilst waiting to see if they have an effect. Then if they have an effect, I'll go forwards with the in consultation with a specialist, and they're about $24 on a private prescription. So for a trial of treatment, it's not too costly. So memantine is the second line treatment. So it works in a slightly different way. It's an NMDA receptor antagonist, and this has really got the evidence around sort of more stage 2, people in stage 2 dementia. So it does have some evidence in helping to reduce some of the escalating agitation and behaviors that might be occurring at that level, and also has some evidence that it probably slows down the transition to residential aged care. It doesn't seem to do much for cognition, and it's more used as a kind of additional medication sometimes. So you can prescribe the two together, but only one can be on the PBS. And usually this one is put on the PBS because it's more expensive than donepezil, but you just have to be careful with your prescribing. It does have some significant side effects, although they're rare, and probably more rare than the side effects that you get with donepezil. So confusion, dizziness, drowsiness, and I would do warn people about these, and seizures is also on there as well. Again, you need a mini mental state between 10 and 14 for it to be prescribed on the PBS. And I guess if you haven't got that, you can prescribe it privately to see if it's effective for some of those more disruptive symptoms.
I think that on the PBS, they are for people who have an Alzheimer's disease diagnosis. So you might find that if they've seen the geriatrician and the geriatrician feels that it's a vascular dementia, that they might not actually trial the cholinesterase inhibitors. And whilst it's not PBS approved for Lewy body and Parkinson's dementia, certainly there is evidence that it's helpful for that too. And so often you find the specialists are prescribing them for that too.
Yeah, and it's particularly helpful for hallucinations. Actually, people who have Lewy body dementia and have quite pronounced hallucinations seem to get a massive improvement with donepezil of those hallucinations. So that can be helpful if they're disruptive. So we talked about applying a strengths-based approach. What do we mean by that, Beck, when we're thinking about optimizing function?
Yeah, I mean, I think it's really important, and the occupational therapists are fantastic for this. So to come and identify the areas where a person is strong, and to try and optimize those strengths and maintain those strengths as well. So recognize those areas and also recognize areas that are challenges for the person, and often have a chat fairly early on about what's important to that person, what they feel that they'd like to work on to be able to sort of maintain function. So for example, if cooking's been something that they've always loved to do, but they've sort of slowed down in the cooking department, if there are easy solutions to really encourage and maintain that strength, things like labeling cupboards, or just making sure that everything's out ready on the bench for them, simple things like that can really improve that ability to function and to maintain an independence as well.
Yeah, and I recently found with my own dad, who's having trouble navigating the kitchen and finding where items are, just labeling the cupboards has made a massive difference, so that he doesn't have to ask someone every time, where does this go, or put things in the wrong place and then be told, you've put that in the wrong place. So having things labeled can be helpful, and they're just simple things and family members, if you've got an engaged family member, they might be quite keen to actually look at that, so they feel like they're doing something to support as well. So that's another. And
starting early, so that you've got that routine and habit in place, that this is where the keys go, this is where you put the leaf blower, and this is where you put the mower, and as you say, have it labelled so that the person can continue to do the gardening. It's just that you always have the instruments in the same spot, and that, as you said, well labelled. And sometimes people's depth perception can change, and their ability to so making sure that things are well contrasting can sometimes be quite helpful. So you might see that the bowl is a different colour to the plate, sometimes I've seen in certainly the nursing home setting, having a different coloured toilet seat can be also quite helpful. So really often quite simple things, but can make quite a significant difference to just function every day. And another thing is just to try and maintain that social engagement too. So often people who have Alzheimer's disease, yes, sometimes they do lose that ability to read and retain early, but actually often things like reading is a skill that they are able to maintain sort of quite a long way into the condition. And that's a really special thing that perhaps they can do with their grandchildren, for example. And again, it's just sort of maintaining that social connection as well, which can be really helpful.
Oh, so we also, it's important to think about other physical health. And I often recommend that people go for physio and exercise physio just to reduce that risk of frailty, which is the other kind of big challenge for people living with dementia and just in the elderly in general. That's another reason why people end up moving into residential aged care. So it's also can be a social activity for having that connection with people and getting people out of the house. And don't underestimate the importance of psychology, both for the person living with dementia and their people around them as well. I think of having the ability to offer people that you can't do it for specifically dementia under a mental health care plan, but you can do it for anxiety symptoms or adjustment disorder to the diagnosis or something like that. All right, so driving and dementia. I feel like we did this the other day. I did this on Monday, actually, a whole hour on driving and dementia. So we'll try and get through a sort of brief overview of driving and dementia.
I think there was actually a question on this.
Oh, really?
So can I just say, Steph, if you don't mind, so yes, we are going to cover it today, but there is actually, there are some good resources, and certainly Dementia Training Australia have done a really good podcast on driving and dementia. And there's a whole webinar on the DTA webpage as well. If you were interested, you could always hop on there. Sorry, go for it. Take it away, Steph.
Yeah, so it's tricky, and whilst a diagnosis of dementia does not mean you have to stop driving straight away, it might do depending on the level of functional impairment, it does mean that probably driving days are numbered. And so it's important, because this is a progressive condition, that we start to have a conversation quite early on about the impact of cognitive impairment on driving. And that helps people with that planning. So, recognizing that driving cessation is difficult for people and that we want that to be as smooth a process as possible. And, recognizing again that individuals' dignity and being offering sort of sensible solutions and coming at this from a real empathetic way, I think, because driving doesn't just represent your ability to stay socially connected and get around and do your shopping. It's also representative of our independence. So we're in a difficult situation as the doctor. We have to tread this line between, advocating for our patients' dignity and respect, and also advocating for the safety of the community when it comes to driving. So do have to have some firm lines, but I think we can approach it in a really genuinely empathetic way, and that can maybe smooth some of that distress out as we go. So at minimum, you need a conditional license as soon as you have a diagnosis. That means that depending on where you are, the onus is on usually the person who's received the diagnosis to inform the Driving Standards Authority of their diagnosis. And then that means that they have to have a conditional license where they come every year at a minimum to have a driving assessment. So the Osroads is actually pretty good with some really good information, and I'd encourage you to just have a brief read about the driving and dementia section in Osroads. So they have a whole thing about what the history that you should be asking, but fundamentally we should be getting a history from the person concerned about their driving. So how do they feel their driving is going? Have they had any near misses, any crashes? Have they started to limit their driving? Are they already only going out at quieter times of the day? Are they only going on familiar routes, only going to very small location? All of those things are indications that they're self-regulating their driving. As with making the diagnosis of dementia, we need to get a really good collateral history. And that's because people can lack insight, and sometimes they can think they're driving really well, but other people will say, oh, not judging distance so well, sometimes drifts into the middle lane, sometimes is a bit heavy on the brake, not always using the indicator appropriately. So all of those things, we need to get that history from someone else. And certainly if family members are concerned about that person driving, with their family members or independently, then we need to take that seriously. So that's the other thing to think about, is that we can actually do some pretty good cognitive assessment tools that help us. So Beck, do you want to just run through these briefly, which ones we recommend using?
Sure. Yes, certainly. So I think one of the take-home messages is that the mini mental state examination is not especially good at predicting driving ability, because people of higher education can actually score quite well on the mini mental state examination, and it also doesn't cover all of the cognitive domains. And certainly in driving, some of the most important ones are the visuospatial domain and the executive function, and neither is covered all that well on a mini mental. So I would say in terms of cognitive assessment, the mocker certainly incorporates those better, but particularly the Trail B, which you can download from the internet. Here's an example of the Trail B, but actually it goes all the way to the number 13 and the equivalent letter. But essentially, this is a really good task. The person has to trace from number to letter. So 1, A, 2, B, etc. And what's good about this task is that it's a test of both visuospatial as well as executive function, as well as attention and the ability to being able to sort of multitask essentially. And it's timed. So there are cut-off scores which enable you to tell what would be considered as normal for that person's age versus, if they've made sort of more than 2 errors or taken longer than 3 minutes, then, that's certainly a red flag that perhaps they're having some difficulties with it. So the Trail B is really good. And definitely another one that's quite useful is the clock drawing task. For people who might struggle with numbers and letters, the Snellgrove Maze is also good. And what's good about this, like the Trail B, is that it's timed. And so it also sort of provides you with a baseline. And if you're monitoring the person perhaps 6 monthly, you can see if there are significant changes to the number of errors or the time that it takes to perform it. And that's always a good way to help the person and their family reflect on what changes have occurred too.
The other thing that can be really helpful with monitoring driving is to ask about function. So we know that if people are having trouble with function that's affecting 2 of their instrumental activities of daily living, so they're having trouble with, for example, banking, and they're having trouble with cooking, for example, then that might mean that then driving is affected. So by monitoring function or asking questions about function, you can get a good idea about whether driving is affected. And certainly if any of the basic activities of daily living, like washing, dressing, those kinds of things are affected, then people probably shouldn't be driving. So I think that's a good kind of thing to enter into the conversation as well when you're asking about driving. Don't focus all about driving itself. Ask some questions about general functioning, or even if it's in the over 75s assessment, perhaps the nurse in your practice might be able to ask some further questions on function, which we might not always have time for, but then you can use that information to guide whether or not you think this person is fit to drive. And the other thing to say is, whilst it's a 12-monthly review, one of the best things you can do is actually shorten the interval. So because this is a progressive condition, perhaps limiting the assessment to 6-monthly or 3-monthly if you're not sure of how much someone is changing over that time. That's a useful restriction to put on someone's license. And
actually oh, sorry, Steph, no, you go. I just realized we haven't mentioned OT driving assessment at all. Do you want to just talk about that too?
I was about to
sorry.
So the gold standard is OT driving assessment, which incorporates all of that stuff we've just spoken about. So the history, the collateral history, the cognitive assessment tools, plus they then will usually use a program called Drive Safe, Drive Aware, which is a computer program that assesses sort of risk with driving. So it flashes up pictures of people at different intersections, and you have to remember where they were going and what they were doing. And then if they pass all of that, so that's probably taken that person, a good few hours. If they've got to that point, then they're allowed to go on the road with the OT driving assessor. And how that works is there's a driving instructor in the front seat of the car with the person, and the OT driving assessor sits in the back seat of the car and observes the whole interaction. And it's a dual controlled car, and it's not the person's car, not their own car. So now you can see, that's why it's $1,000 or however much it is, because it's actually very involved, and it is gold standard because of all that direct observation that you've got. The beauty of it is it actually can be used as a rehabilitation process. So if there's tips and tricks that they can offer or support, again, thinking about that strengths-based approach, it might be that the person can actually continue driving. And we can get to the point of having done the cognitive assessment, having done that really good history, and then give the person a really good understanding about, well, you haven't done so well on this trail A, not done so well on this one, we've picked up a few issues in the history. Perhaps a driving assessment on road isn't the right way to go. Perhaps now's the time to think about driving. You can give people a kind of option, but they might then choose to stop of their own accord. So that's the other way. And we don't routinely recommend using the licensing authority for those driving assessments, because usually then it's just the driving person and the person the person who's being assessed driving. So there's not a third person there. They're not necessarily trained in all of the things that somebody with dementia might be experiencing. So, and you have to think, this is a safe environment if it's not a dual controlled vehicle. All right, so legal then. If you remember the checklist, we're just going down the checklist that we showed you before. So we're now onto legal considerations. So we want to make that diagnosis in stage 1 so people have the opportunity to do some of these legal and structural things. And, up there is the will, which, often people will want to make changes or make sure that their will is up to date when they've receive a life-limiting diagnosis. But people have to have the ability to make those decisions and the capacity to make those decisions. So that's why we need to make sure that the diagnosis has happened early enough for that to occur. Appointing a substitute decision maker, so just makes things easier. I had a patient today whose mother was diagnosed actually quite late. She no longer has the capacity to make these decisions, and now the daughter is having trouble speaking to my aged care because they're saying, well, you don't have the right to speak on your mother's behalf. We have to speak to your mum, and her mum has barely got any verbal skills, so she's not able to speak. So now she has to go through the SA tribunals, and then there's another paperwork and forms to fill in, and it's just a long-winded process that when you're in that situation of being the carer, you just don't need that. So just about being proactive. So the same goes for advanced care power of attorney. I'm not sure what it's called in Queensland. I've learnt now that in Australia it's called something different in every jurisdiction. But basically, usually you have somebody who is the person who helps you make decisions about finances. You also have somebody who helps you make decisions about lifestyle and medical issues. And those two people can be the same person, but the documents are usually different and they're called a multitude of things. I've just done this with my dad, and it's hard to do this, but when you do it well, I think it can be really advantageous, and people find it hard to talk about these things because it is, you know, it's not nice talking about end of life and death and what do you value, but actually I think it can be really helpful. And I think one of our roles as the sort of primary medical practitioner is to signpost people. We don't have to do it for them or do it with them, but we can at least encourage them to do it, start the process, perhaps signpost them to organizations that can help walk them through it, so that it's all done. So, Beck, we're hurtling towards the end, I feel, because we always have this at the end.
Yeah.
Family and carer support.
We do know that carers, can find living with a person with dementia can be extremely difficult at times. And so, firstly, we do know that providing good education, regular visits can help them, and as I mentioned before, also enable the person living with dementia to actually stay at home for longer. But I think you can't underestimate the impact that it has. And it's not only when they're living at home, but I mean, I still have people coming in and they worry about their parents who are in the aged care facilities too. It's an ongoing, constant concern. So if they are your patient, then I always talk to them also about a referral potentially to see a psychologist through a mental health care plan. And if they're not your patient, then certainly signposting them to that. Dementia Australia, as Steph mentioned, has some fantastic local organisations which are, groups that carers can use as support groups where they can get together. And then there are other things like Carer Gateway, which can be useful, particularly in the situation that Steph mentioned where, respite, for example, hasn't been arranged and there's sort of an emergency. There is sort of an emergency Carer Gateway number that you can contact. When people are experiencing the changed behaviours, that can also be quite isolating for the carer. So again, Dementia Australia have some fantastic help sheets on that. But DSA, so Dementia Support Australia, can provide education. They can even come out to the house and have a look to see if there's anything particular that they can suggest in terms of non-pharmacological interventions, etc. Here you go. That's the slide to show you Dementia Support Australia. And that's great for carers. It's also great for nursing care facilities and also for health professionals. So there is a GP line that you can contact via email, and they can provide you with some fairly individualised advice, both from a non-pharmacological perspective and then for those more challenging cases with some pharmacological options as well.
Oh, my sneeze caught up with me.
Yeah.
So
I mean, yeah, go on, you go.
You go.
Oh, that's fine. Well, this is also a little bit close to my heart. I do think that regular review, I can't underestimate it. So just bearing in mind that the person living with dementia almost certainly has other medical comorbidities, and making sure that they're well managed will also help their cognition. So if you have somebody whose heart failure is really poorly managed, that will ultimately also impact on cognition. People who have other sensory impairments, so people with difficulty with their vision or their hearing or even peripheral neuropathy, all of those things are cumulative. So making sure that we've addressed hearing and vision is super important. One thing that often gets missed is dental health. Certainly, I would try and encourage a fairly early dental review, because by the time a person is going into residential care, it's often really hard to get dental reviews done. And so treating mouth care is very important. And we do know that, again, as the dementia progresses, when swallowing is reduced and sort of communication is reduced, you don't get that sort of increased salivation, and so people can get a very dry mouth, and that can lead to infections and ill-fitting dentures and pain, it's really important to think about the mouth and think about dental health. Again, bone health is something that we need to consider, particularly as these people are at increasing risk of falls. And so making sure that a bone density scan's done early, and if there's any osteoporosis recognised, to implement some changes there. And we use weight as a really good measure of how a person is looking after themselves. But also, again, in the later stages of dementia, significant weight loss of 10% or more is really a red flag that perhaps we're entering more of that end-of-life care stage. And so, yes, consideration for nutrition throughout each stage is important. And yeah, I would encourage a 3 to 6 monthly GP review, bearing in mind on the stage and bearing in mind that at each stage our goals of care will change.
Yeah,
this is
just a reminder. Yeah. And remembering that those risk factors, whilst we talked about them pre-diagnosis, they are just as important post-diagnosis. So, you know, making sure that people have got adequate social contact, that they are, you know, getting out and doing some exercise. And those are the kind of two that I focus on because they're kind of easy to sell, and people are often, you know, they're free, aren't they? So if you go and do some exercise and meet up with people, it's less challenging than having to focus on weight loss or something like that. They're kind of easy ones, and I think we get good benefit for that. But also thinking about, you know, hearing and vision and all of those other things is so important. So I'm amazed that we have managed to crawl back to the finish on time. Hopefully we have illustrated these three things. So again, our take-home message is 45% of dementia is attributed to modifiable risk factors. This is not an inevitable consequence of aging. This is something that we actually have some key moments in life to make a difference, and we should start thinking about that in the people that we see day to day. That once people have received a diagnosis, the GP can make that diagnosis and can definitely initiate care. And I would say, in my experience, just because someone's seeing a specialist doesn't mean that all these other things are being done. In fact, they're often not. And so we do need to sort of pick up the pieces, because, you know, it can be difficult for specialists to organise some of this social stuff. They don't always have the time either. I'm not saying we have the time, but we at least have the we don't have the time necessarily. We can make time by seeing people frequently and often. So it's like longitudinal time rather than time in the appointment, if that makes sense.
I think you're being very kind, Steph. I think, like, in my experience, often people will be given a diagnosis and then sort of told to come back in 6 months and really given very little. So that's where we've got so much that we can offer.
I didn't want to be too disparaging, but
sorry, that's not always, but
I'm being generous. Yes. Well, I do also think that I think that some of the messaging that we talk about in our talk is quite, like, it is quite cutting edge. Like, it is stuff that maybe people haven't learnt about in terms of all the things that you can do for somebody living with dementia, because this stuff, you know, people weren't familiar with rehabilitation or the strength-based approach, and probably some of our specialist colleagues haven't had that education either. So giving them the benefit of the doubt as well, maybe they haven't had that. So you'll be ahead, you'll be leaps and bounds ahead. So has anyone got any questions at the end of that? Yes, this is our resources, which are, as Beck said, about to be updated, but the Dementia in Practice podcast is still available wherever you get your podcasts and has loads of excellent episodes. And that's it.